my topic has been to talk about how to select. So when Ranjan gave me this topic, I was a little confused whether to select a device or to select a patient. So I thought I will talk about both of them. Next slide, please. Can you go on with the slides? Oh, I have. Okay, so we will talk about both of them, a little bit of it, and if we have to go straight forward as selecting the patient, we know it is very simple because you know that whenever we have a patient who is not responding to the standard treatments like the inotrope and all, and he is getting escalated on inotrope, we naturally should consider any of the devices as it has been discussed in the previous talk. And as far as the assist device, we had a large armamentary a few years back, and now the third generation assist devices are available, and it is now almost we are fixed with the one device which is called the HeartMate II. So this is one important thing which like we have been discussing about shock grading, which we follow, we the heart transplant surgeons, and where we take care of these heart failure patients where they are waiting for transplant. We keep grading them as per the heart transplant surgeons, and where we take care of these heart failure patients where they are waiting for transplant. We keep grading them as per the Intermax, which is you can see the level 1, which is we call it as critical cardiogenic shock, progressive decline. In fact, if you can come their worsening situation from level 7. First, when they go to level 6, their exertion is limited. Then exertion is intolerant. Then we see frequent admissions where recurrent cardiac, they are admitted for failure. Then they get into ICU with inotropes, or sometimes we send them available where we can support the right heart, which I think even Dr. Karnathan has been describing well about this impella. So these are the scenarios where we need VADs, especially like when patient is in the Intermax 1 and 2, and this I would like to skip because we had this discussion in the previous talk where we use IABP and then ECMO plus IABP to prevent the left ventricular distension or decrease the afterload. Then the impella plus ECMO for treating the shock. Then impella right whenever you have a right failure. And the Centrimac is one thing, armamentarium in the surgeon's hand where we use in certain situations where we have biventricular failure or even left ventricular failure. So why do we need the mechanical circulatory device or a VAD? So these are the three main aspects, either bridge to recovery or bridge to transplant or as a destination therapy. Whenever we put a permanent VAD, that is once recovery with a destination therapy. So as we have been discussing all throughout the conference, the mortality of an acute decompensated heart failure is roughly 30 to 40%. Sudden cardiac death in heart failure patients is 50%. So, and they keep progressing to renal functions. So we can't keep patients, for the non-availability of the heart, donor heart. So these people will be needing ventricular assist devices, depending on their affordability and also their clinical situation. So this is one important graph which we see the mortality, which if you don't use any assist device or the mechanical circulatory device, the mortality is really high, especially in the Intermax 2 to 3 situation. But when we have an NVAD, the mortality is quite low. So this is the prognostic indicators which we take when we want to decide, when we want to put a patient on a VAD. See, these are the admission profile with a poor outcome. Generally, we consider that this patient may lead into further deterioration of his clinical condition. And we can come back to the presentation. So this is another situation where we had a small child who was shifted to us with in a very biventricular failure, and then we considered whether we should put on an ECMO or a BiVAD. Patient was having severe RV dysfunction and also hepatic dysfunction with bilirubin of nearly 20, and we decided it acts like a displacement device. This slowly got developed into something called pulsatile one, which had a motor, but it would be implanted into the patient's abdomen. And we had the, in fact, when India, it was first done in All India Institute. When I was training, we had the chance to work with these devices, but they were discontinued, and slowly these are the devices like the Novocore, which started developing. And then one of the best clinically used was an axial flow device, which we call as HeartMate II. And this had a good run for quite some time, but there were a lot of issues because of the pump getting stuck, because of the thrombosis of the pump, and there had to be a lot of reoperations to be done for it, and also there was a high incidence of stroke. So this slowly got developed into, this is another axial flow pump which we had used in our patients. This is called the Jarvik 2000. And the main problem with these pumps is the stroke rate is very high. And slowly you can see the difference of the thing.